Julia, and nice to meet everybody. So as Julia says, I'm a GP partner. So I work in Runcorn, so we are definitely in that core 20% deprived population. And we have taken a kind of team approach to this. So we have 8 GPs, we have 3 NPs, and we have a HCA, and we've recently recruited a pharmacist as well, starting soon. So we try and always use a one-stop approach in our practice to multimorbidity, where we try and get patients in and deal with all their chronic disease in one appointment. And so I've been asked to talk about how we made this work in the context of multimorbidity and a deprived population. So I wanted to share our experience of how we, through the pandemic and beyond really, how we've used remote reviews, how we've used digital first triage, and these risk stratification approaches for chronic disease reviews here in Runcorn. So I'll talk about what we did, I'll talk about patient outcomes and our experience of it, and I'll talk about our next steps in that as well. So you've heard already about the UCL Partners Proactive Frameworks, and I came across them when I started in Runcorn, and I was leading on asthma cough, and I needed to come up with some kind of approach for how we were going to do our cough work before it was, put off. So I started to look at these remote digital asthma reviews for low risk patients, and I was using Accurix Flores, and we developed an Accurix.
Sorry, Lauren, you're not sharing your slides.
Oh, right, okay. I'll start that again then. Apologies there.
It's okay.
Can you see that now?
Yeah, there you go.
Excellent. Okay. So so apologies for that. So what we did is we came up with this Accurix in-house template, which we could use with our low-risk asthmatics. And then we also looked at the same time, the CCG locally was looking at mHealth, which was an app which was to support, especially promoting with low-risk asthmatics and diabetics. And we could use these UCL searches to try and find these patients and target the mHealth. At the same time, another project we had going on was lipid optimization, and that was working with medicines management pharmacists and contacting these patients for a proactive review. Another stream of work that we've always taken this one-stop approach, and we always use this making every contact count, which obviously a lot of other practices are becoming aware of now. So our vaccine clinics, we were seeing a boom in attendance, and we came up with some screening templates to capture BP, weight, alcohol, smoking, chronic disease monitoring for those attending or booking for their COVID and flu vaccines. And then we also started to explore the AFQI and BPQI tools that Jane's helpfully spoken about earlier. So they're amazing tools. They risk stratify your CVS patients. And at the same time, we were able to target the loans of the BP meters that were provided by the CCG. And we could try and filter out our complex multimorbid patients into our one-stop clinic, which is this Brookvale approach that we've done for years. So this was what I mentioned earlier, the in-house Accurix that we came up with. Lots of practices doing a similar thing now. So you can attach your asthma plan. I attached links to videos for inhalers. And then we were asking people if they couldn't access it, they could just get a printed version. And if they needed a new peak flow meter, we could provide that. And through, again, innovation agency contacts now, we've managed to get hold of peak flow meters that we can hand out to our most deprived patients, because we were finding that was really limiting our remote reviews, and for acute asthma as well, it was limiting people self-managing because they couldn't afford to pay and pick up a peak flow meter from their pharmacy. So this was the reception template that we made. So Jane came to our practice and did an amazing piece of work training our first front of house reception admin team and our HCA. And we came up with this making every contact count template, so that when people were booking into clinics and attending at vaccine clinics and other clinics, we were able to upskill staff to be able to feel like they could safely provide a BP meter to a patient and instruct them in how to use it. So that was that part of the template. The other part of it was whenever people were calling up and booking for vaccines, we had receptionists doing quick kind of signposting work. So the ethnicity work really helped when it came to that project. And then we had smoking cessation advice with local links there, asking about elderly falls and appropriately acting on that as well. So the BPQI, Jane's already talked about beautifully, and for our practice, the way we applied it was the filter that Jane alluded to earlier. This is incredible. You can filter off your highest risk hypertensives also by patient group, and I really want to hammer that one home, because for us, for a multi-morbid approach, it was a really powerful tool. So we could pick off our learning disability patients, our CKD, dementia patients, BAME, stroke, and we have our one-stop clinic set up where we have a HCA, practice nurse, ANP, diabetic respiratory lead, and myself, GP, mopping up the other stuff, and we could filter off our highest risk patients and get them into these face-to-face reviews and really focus on them. So looking at patient outcomes, we managed with all this proactive work, so it was separate streams to it, but it all worked beautifully together. We had some really good outcomes. So our HCA, Jen, managed to do a bit of work where she looked at some outcomes from this, and we managed to weigh, we have a list of 8,600, we managed to weigh 3,291 patients between January to November 21. And 593 of these were actually in the vaccine clinics. And as expected, really, people did gain a lot of weight in the pandemic. And we also found some new hypertensives and new diabetics by this proactive work of doing the blood pressures. We had pre-existing searches so that clinicians in the vaccine clinics could see if somebody was due a blood pressure or weight, or if they were due a HbA1c check, if they were previous pre-diabetes or gestational diabetes. And we picked up lots of new cases. The second outcome that came from the separate stream of work around the asthma reviews meant that we managed to keep our number of asthma reviews maintained at the pre-pandemic rate just by remote working and risk stratifying, basically. So you can see the numbers there: 372 pre-pandemic year, 391 pandemic year, 389, and that was only that was a couple of months off the finish when we last looked at that. So we also looked at adjusting even for low risk patients only. Patients had few exacerbations and urgent care contacts via remote or face-to-face review rather than telephone review. And we have this hypothesis from talking to patients and staff that it seems to be that having the asthma plan and video link sent to them and be able to refer to in future was something that was subjectively fed back to us as being helpful for that. So people that like data, we just looked at a comparison between the remote digital reviews, telephone reviews, face-to-face reviews, and no review at all in that period of time, and then some relevant patient outcomes. So number of people having exacerbation, number having more than 3 SABA issues, and with no ICS, number smoking, number with an admission or urgent care contact. And the green figures are low risk patients, and the black is the total. And we found that actually, surprisingly to a lot of staff, the worst outcomes were for patients that had a telephone asthma review compared to face-to-face or remote digital, and even when adjusted for filtering out your low-risk patients. Another learning was that a lot of our patients smoke, but Rhiannon will say the same from nosy as well as similar population. So looking at our experience, so patient uptake was very poor with mHealth. So this mHealth app, we came into it really enthusiastically thinking it would be great for our low risk patients. We were filtering off all our low risk diabetics and asthmatics, promoting it to them through text message campaign and through when clinicians were having contact with them. We had extremely poor uptake, which we fed back to the CCG. So 2 COPD patients, 9 asthmatics, 6 diabetics, and 2 heart condition patients. And the eldest was 69, but numbers actually using the app. So we tried to monitor when people were going into the app, and it was even worse actually. 3 asthmatics actually used it, 3 diabetics, and 3 heart patients. So we can't tell you any more about why that happened. Feedback from a few patients that we've interviewed had been that they felt it was just another thing to use that they didn't have time for. We do have obviously a quite deprived population, and we have lots of people with English as their second language, so it might have been more related to our practice population as well. BP at home was a roaring success with the BPQI targeting and then proactive work around that from the vaccine clinics. We had really good uptake. Last count, which was a few months ago, 158. Only one who hasn't brought it back in this time, and same for oximetry at home. I'm sure everyone was the same. We had hardly any attrition there. Staff experience, we've been finding quite a lot of replication of work. The real difficulty is aligning our recalls process for QoF when QoF started restarting, and that's work in progress really. QI has got a bit of replication for us with the PCN pharmacy work going on, but it's still a really helpful tool. So our other experience is that we've had very few COPD low risk patients in our population, and doing risk stratification here is not really working for us because only a few qualified for low risk remote review. A dedicated respiratory nurse really helped here, but we're really proud of her. She's moving on to do a nurse manager role. But on the other flip side of that, we have a pharmacist starting soon who can take more of our low and medium work on, so that'll give us more chance to do more face-to-face and higher risk. We've had the curveball of the pheno targets that we need to do, so a lot more people now need to come in face-to-face to do pheno, so that's limiting more of our remote reviews. And as I mentioned, we have a lot of smokers. 43% of our register are smokers for asthma, and it does really make our register higher risk than it may appear in UCL searches. So we have a lower threshold from our experience of bringing smokers in to face-to-face review. So next steps, we really want to get some objective patient feedback measured by survey to see what the acceptance was around these digital and more face-to-face one-stop reviews as well. As I mentioned, pharmacy-led review, the lipids project experience showed that this was really well accepted by our patients, and we think it's going to work really well with clinical areas such as asthma and hypertension. Really excited about that. We are now doing more clinician-led high-risk recalls. So we've got our parallel admin-led QoF process, and then we've got clinician lead for that QoF area who's doing the high-risk recalls and making sure that things are targeted. We've done the peak flow lending protocol, which is coming in where we've really struggled to get peak flows to people. Now we've got supply that we can give to people. And the screening template blocked our phone lines a lot of times, so we're making it more about afternoons and looking at new staff now and seeing how we can start that up again before winter pressures hit. So we're aligning with our core 20+5 objectives, and because doing more low risk remote reviews frees up more time for these proactive work with SMI patients and proactive case finding. The most important thing that we learned is the worst patient outcomes were for those with no reviews at all, and it's really unclear to us if digital or remote reviews help or hinder this group to engage. We're kind of growing more and more on one-stop. I'm sure this is happening across the patch. So our numbers of complex multimorbid patients are growing all the time. So we've grown into 2 one-stop clinics a week. We've got a growing team around it as well. The stratification work there is really helpful because we can target who we bring into those clinics.